So a huge welcome to you all for joining us at today's big innovation conversation. My name is Katie Whittle and I'm Programme Manager for Patient Safety at the Innovation Agency. We're joined today by Andrew Cooper, who is our Associate Director for Patient Safety, and we also have Becca Wardle on the call, who is one of our project managers for Patient Safety, and I think Connie Shellerick has also joined us from the Patient Safety team as well. I'd also like to introduce you to Phil Wright, who is a member of our events team, who will be facilitating this session from a tech perspective today. The way that today's session is going to run is I'm going to give a brief overview of why we're here. I will introduce you to our guest speakers who will talk to us about the innovations that they have in response to sort of recognising deterioration and keeping our residents safe in care homes, and then we will have a question and answers session to wrap up at the end. So if you've not joined us before, our big innovation conversations are a series of monthly discussions that showcase innovations and solutions which can improve health and care. Here at the Innovation Agency, we classify innovations and solutions into categories and themes which reflect the transformation and redesign of the challenges that we're all facing together as our health and care system becomes more integrated. And to do this, we support a culture of innovation that helps the system transformation and improves care and safety through the adoption of these innovations. In addition to this, we work with local health and social care system to improve patient safety through the adoption and spread of proven interventions and the delivery of local patient safety collaboratives. We host the Northwest Patient Safety Collaborative, and we are one of 15 collaboratives that forms a national network, and we're commissioned by NHS England and Improvement to do that work. A main focus of our piece of work is around the care and safety of residents within care homes, particularly in relation to early recognition and responsive deterioration and prevention of falls. And therefore, today's conversation is going to focus around that and how we can achieve that. So first we'll hear from Jamie Stewart at Safe Steps, and Safe Steps is have designed a digital falls risk assessment tool designed to reduce the number of falls in care homes, and have also developed a COVID tracker, and they're going to tell us about the success of that and how that's going in Greater Manchester and the offer that we have here. We'll then hear from Dr. Rahil Sidqam, who's co-founder and director of Sidqam, who are one of the approved developers of a digital solution for Restore 2. Restore 2 being a tool that's been specifically designed to recognise deterioration in residents in care home environments. And then we're going to hear from Dr. Stuart Grant, who is Chief Medical Officer at Rinicare, who have developed a portable and wireless solution for vital signs monitoring, and have also developed a tool for around falls as well. So before we start, just to let you know that the chat box has been muted, but there is a Q&A box. So please feel free to populate that with any questions, thoughts, and any feedback, and we will keep an eye on that as the session progresses. We will address any questions that have been posed at the end of after each speaker has spoken, and to facilitate our question and answers session as well. Just to let you know that you have been muted throughout this session as well. So please do use that facilitation, and that's just to stop any interrupts and so that we can hear our speakers clearly. So I'm going to just give a little overview of why we're here at the moment before I hand over to our speakers, and just to thank you again for taking time out of your busy schedules to join us today, and I hope that today generates a lot of discussion and gives you some food for thought. So when we talk about where we are today, this is all in relation to the NHS Patient Safety Strategy, which was developed and launched in July last year. Really exciting concept, first of its kind, and this is about creating a safer culture, safer system and safer patients. It's underpinned by 3 strategic aims. We have insight, so improving the safety by drawing intelligence from multiple sources of patient safety information. We have the involvement aim of equipping patients and staff and partners with the skills and the tools and equipment and opportunities to improve safety throughout the system. And then we have the improvement arm aim, which is designing and supporting programs that deliver effective and sustainable change within the most important clinical areas. So when we look at this, just moving on, sorry. This is where the National Patient Safety Programme falls really quite nicely, an absolute key component of the National Patient Safety Strategy. and is delivered to cover 5 national priorities that have been identified by NHS England and improvement. And these are all underpinned by creating a culture of patient safety, building improvement capability, working with patients, carers and families, that leadership and clinical leadership of patient safety, which is absolutely crucial, and specific work stream interventions. So today we're talking around the managing deterioration work stream, and we have 3 aims for this work stream: reducing deterioration associated harm and mortality in adults, increasing the safety of patients and residents who are at risk of deterioration, and increasing system coordination around deteriorating patients. And this will all be achieved by building safe and reliable pathways across the whole system, taking all cause of acute physical deterioration into consideration, that whole system approach. So we are building that collaboration and improving communication between community, primary care, acute and social care settings, so that no matter where a patient enters the pathway, they are recognised and the tools are managed and the language that we use is recognised. So we've got that common theme throughout the pathway here. So this will all be delivered through 4 peer interventions. So we are looking at the planning and preparing some interventions to reduce the risk of deterioration associated harm prior to deterioration occurring, so taking a very proactive safety 2 approach, and this is including the awareness of taking into account what risks might happen and how we're going to mitigate against them, both from an individual level and from a system level as well. So it's making sure that we have pathways of transfer of care throughout the system, that coordinated approach, ensuring we know our residents really well and what their baseline is, reducing the potential for inappropriate transfer and treatment. So having those early discussions about whether residents would benefit from being transferred into an acute care setting, and equally back out of hospital again, have we made a decision to whether it would benefit a resident being readmitted. Having that safety culture, strengthening the voice of our patients and our relatives and carers, and building that improvement and human factors capability within our workforce. We're then looking at that identification, and this is where the early warning system and early warning score comes in, and a tool called Restore 2, which is, as I've mentioned, a tool to recognise deterioration in care homes, and that incorporates the soft signs and those early signs of unwellness, the early warning score, and a structured communication tool such as SBARD, how we then escalate those concerns and how we respond to those in a timely manner. And I think from a perspective today, we're really fortunate to have 3 key speakers whose products all fall in line with this really very well, and from that monitoring and that prevention, and how we can then escalate and prevent falls from happening, and how we prevent deterioration and then monitor those who have deteriorated and escalate in an appropriate fashion. And then having the use of digital solutions as well from a remote perspective, certainly as we move forward into our new ways of working, sort of virtual wards and remote monitoring and assessments. So I hope you really enjoy what we're here to learn today, and I'm going to hand you over to Jamie first of all at Safe Steps. Thank you, Jamie.
Thanks very much, Katie. So I will just put some slides here. So yeah, I am Jamie Stewart. As Katie mentioned, I'm the partnership manager for Safe Steps, and we are now, one of the fellows that's been invited onto the NHS Innovation Accelerator to really push for spread and adoption of our products, because it's massively impacting some of the most vulnerable members of society. We've done a lot of work with the Innovation Agency in the past. We've also worked with a number of other areas, including Health Innovation Manchester. I see there's a couple of the team here on the call today. Traditionally, Safe Steps was developed as a falls prevention app and an ability to reduce the risk of falls in people in care homes. Now, falls happen everywhere, and care homes traditionally house some of the most vulnerable members of society. If we can track and reduce the number of falls there, then we're stopping these residents falling into hospital settings, and ultimately we all know that after residents have had one fall, they subsequently lose confidence and will go on and rapidly deteriorate. And that is something that, you know, a few of us in the business have unfortunately had personal experience through various members of the family have had falls. Everybody knows somebody who's been affected, and often we forget that the individual that's had the fall is not the only one that's affected. It does have a knock-on effect to others in the family. So from there, we identified that there must be a better way of doing things, and we know that falls risk assessments are being carried out in care homes. The problem is there's no standardised approach to it. So we've worked with you know, the 12 NICE guidelines to standardise the approach. It's totally digital, it's easy to use, it's on an app, it's a web app, so there's nothing to download, and it's very, very intuitive. Ultimately, throughout the platform, at every stage, there is advice and guidance and support provided to care staff, a bit of a how-to, and ultimately the feedback that we've had is that this aids any kind of training and development for the staff as they go through it. It's a multifactorial risk assessment, and to identify early risk indicators for residents. Now, it's customisable to each kind of area and each individual care home to ultimately create a personalised action plan for these residents. The aim is to prevent falls. Now, we collect where they're happening, when they happen. It'll identify trends and ultimately aim for continuous improvement across care homes and across localities. It double benefits as you also get a full audit trail and a digital audit trail that's accessible at any time, anywhere, that aids in things like CQC inspections, rather than rushing about trying to find where did we put the paper applications or the paper reports of each of the residents. As we said before, fully built to NHS compliance, already live in over 130 care homes. Thousands and thousands of screenings being performed. Some of the data that we've shared across multiple localities show a 28% reduction in the number of falls reported post-implementation of Safe Steps, which is absolutely fantastic when you consider that on average a fall would cost the NHS circa £7,500 per fall. Obviously, once you've had one fall, it does then lead to, unfortunately, further falls, further costs involved there as well. What happened in March was, obviously, we were part of a response to COVID, which grabbed the world's attention. We realised that again, like falls, residents in care homes are susceptible to contracting COVID, and it can be equally as problematic for them, and if not more so than your average resident. So we've pivoted our product to quickly be able to track hotspots within care homes and identify where clinicians need to interact and ultimately provide care as quickly as possible for these residents. What you can see on the right hand side there is an overview of the usage of the tracker. You see, are they displaying symptoms? Are there any confusion? And where are they in terms of a red, amber, green status? At the quick view, anybody across the system can go in, see the status of all the residents, either in a care home or across a locality, or across, you know, for example, we're working in Greater Manchester, you'll see an overview of what's happening across the whole area. This doubles as a bit of a tool for development for future work in terms of housing the ability for remote monitoring in care homes. Obviously, Katie touched on that before. We're building in some kind of early warning signs. We're working with Wessex EHSN to design and digitise the Restore 2 platform that's subsequently been built into our tracker, and will help identify deterioration as it happens. Now, as you said, you'll get an overview there of what the tracker looks like from a carer's point of view. Super easy to use. And then if you were to press the data and reports card, you would then go on to see a bit of symptoms, down the left-hand side of that, where we would track that in a daily instance. And it also helps homes identify, have they got any advanced care plans in place for these residents, and the GP associated with each care home will have a look at that, and will be able to make recommendations according to how they see the trend of the resident's health is, and ability to act accordingly. One of the more recent features to be added, as I said, was the Restore 2 Mini. Ultimately, it is a softer signs capture for these residents. It's the ability for carers and staff within care homes to ultimately say, I know my resident better than anybody. I know they're not themselves, but they don't have a definitive way of personalising that and portraying it. There's frameworks there from Wessex. We've worked with them, and we are now one of 3 kind of chosen partners to work with them to digitise it, and it is in the process of being rolled out across Greater Manchester. Obviously, you'll see there as well in the centre the SBARD framework that Katie mentioned before. Ultimately, it is there. You use that, you'd phone the digital hub, they'll give you advice how to best deal with the residents' deterioration. The aim of all the tools is to aid quicker decision making and ultimately look after these vulnerable residents. Some of the kind of major headlines in the falls tracker, as I said, over 13,000 screenings, 28% reduction in falls across most settings. Some actually showed a larger than 28% reduction. We're in care homes, we're in hospital settings, we're in communication with rolling out to a dom care setting for falls reduction as well. We're fully aware that falls do not just happen in care homes. On the right hand side, you'll also see a milestone for the COVID tracker. Over 100,000 assessments have been completed now on that, and obviously it is a milestone, but we understand that is not going to stop there. It's going to keep getting used, and ultimately we want to see this number grow, because it means that more residents are getting tracked, more residents are getting access to faster and better clinical decision making, and that's where we are as a company. The information on the screen there for anybody that does want to get in contact directly with us, it's simple hello@safesteps.tech. The website's there, and obviously the details will be shared after the webinar today. Thanks, Katie.
Thank you. Thanks ever so much, Jamie. Great presentation, and really great to hear about how this tool has really been embraced and is helping prevent so many falls, but also the developments with regards to Restore 2 Mini also. So I just got also a congratulations on hitting 100,000. I noticed that this morning on Twitter, that it helped screen so many residents. I think that's absolutely phenomenal, and in such a short space of time as well. And I'm sure, actually, although we know this is in Greater Manchester, I'm sure actually our participants today will be really interested in that, and hopefully that's going to really stimulate some conversation as well. So I suppose I'm not sure if I can see any questions in the chat box. I can't see anything in there at the moment. But I've got a couple of questions for you, and I think it's, what sort of feedback have you had from staff with regards to using the tool itself, and from a falls prevention perspective, but also with the situation that we're in at the moment, how's the COVID tracker been embraced, and how is that inclusion of Restore 2 Mini really helped in that recognition of patients and residents that are deteriorating?
So I suppose the easy answer to cover both is we're very, very lucky that we've got a fabulous designer that works with us to design and develop both apps. Really, really simple and easy to use is the repeating message from care homes, from clinicians. It does what it says on the tin. It's there, and it's so simple that one of the main barriers, if you like, to the COVID tracker when it was coming in was care homes, as we all know, were very much almost abandoned at the start. They were getting asked to fill in numerous different spreadsheets, report back data to numerous people in different formats, and it was almost seen as something else to fill in. But when we conveyed the message across that actually this is going to standardise the reporting for you, You fill it in once and it'll go, and it's so easy to use, and they've instantly taken it on with, you know, with open arms, if you like. They actually, the feedback's fantastic. You know, every care home that we speak to is just, this is so simple, and the work that they're doing with the clinical hub in each area that we're in, they're seeing it instantly as soon as the care homes are updating that data. People like Professor Martin Vernon, people like Dr. Saf Ahmed and Tameside, you know, they're instantly acting on the information, and they can see care homes that are needing attention there and then, and acting on it. And the care homes are thankful for that, because they feel as though they're helping, and they are helping. That's exactly
and
it.
I think to be able to implement something new in such challenging times, and to have such positive feedback that, you know, a new system, a digital system, is being embraced and has been adopted so quickly, is really encouraging. We've just got a couple of questions here as well in the chat box. I've got Mark Arnold who's saying, hi Jamie, I can see how the system aids decision making, which is excellent. Are there any ways that it improves the transition to and from the ED department, communication perhaps?
It's obviously, the information is portrayed to the digital health hub. So the idea being that we can keep as many of these residents out of hospital and out of the emergency department before it's too late. You know, if we can preempt any kind of change in behaviours of these residents in the care home before it, you know, it might be missed. So.
And I think this is about having that common language for us, Mark, as well. With once you've got having sort of that common language of Restore to, but News 2 as well, in the early morning score, and be able to communicate that through the system. We've got just two more questions that I'm going to pop into before we move into our next speaker. Who is part of the clinical hub that respond to the information being through the app?
So it can be anybody from GPs, obviously, looking after individual care homes. It can be lead clinicians across each locality. It can be whoever is best placed to help the residents, whether it's pharmacists, whether it's anybody that's involved in primary care.
Yeah, great. And I hope that answers that question for you, Jane. And how do care homes store the information from the app? Are there plans for a reporting function?
All the information is saved through the app into the cloud. There are reporting functions available through dashboard displays for overall localities. We can identify trends as they happen, be able to look back and plan for future, what's happened from March until now, as we move towards potentially the second wave. You know, we can take lessons learned from the first time and hopefully improve and look after these residents. That's
great. Thank you very much, Jamie. I'm very conscious of time, so I'd like to just move on to our next speaker and introduce you to Rahil. And to be able to talk about the digital solution that you've been involved with regards to digitalising Restore 2. So thank you very much, Rahil.
Thank you so much, Katie, and welcome everybody. I'm Rahil Qamar Siddiqui, and if I just share my screen, first things first. Right, hopefully everyone can see my screen. So I'm the co-founder and director of Sidqam Limited, an ex-NHS staff who really was and still is really keen about building standardized and structured clinical systems, not just to improve the way the systems work and respond to rapidly changing healthcare requirements, but also that they are interoperable with other system providers to enhance how data is used between different care settings to provide the best care to patients. So what I'm focusing today on is the Direcht Restore application that we've developed in partnership with West Hampshire CCG. Like I mentioned, it's a digital implementation of the Restore to paper tool. Now, this was pioneered by West Hampshire CCG, and we're working in partnership with them to digitize it, which ensures the sort of level of clinical safety and adherence that they would expect out of systems wanting to digitize this service. So it is a physical deterioration and escalation tool, and it has things like, you know, capturing soft signs. In that, we've expanded it to also capture COVID-19 symptoms, and there are certain alerts that trigger if you capture more than 2 COVID symptoms, and the way that the system responds to it. We've got the National Early Warning Score based on the core vital signs that are captured on the patient, which leads to a certain clinical pathways, and then a structured communication. So the aim is to really simplify it for the user, so that the care home worker is pretty much shown the next step that needs to be done, and the journey to getting the best treatment for the resident is achieved. It's based on certain standards. So like all our clinical systems, Digital Restore tool also has the same sort of standards. So we've implemented SNOMED CT, and all exchange of information between different systems is through HL7 file. So yeah, actually the paper Restore tool is spreading quite rapidly throughout the country. So West Hampshire CCG and Wessex AHSN, they both collaboratively pretty much spread the scope of Restore to nationally across 20 CCGs and growing pretty much on a daily basis. So what are the sort of issues that we typically find within care homes? I've tried to focus just on the care home workers and clinical staff, but actually it does extend into residents and other support services. So the time, of course, you know, how do you capture the physical deterioration of a resident in time to prevent rapid decline of the condition of that resident? Second thing is access to data. Now, if we can get the most relevant data about the resident instantly and communicate it without having any sort of gaps in communication and what's passed on to the next healthcare professional, that would be excellent. So we do find some gaps in terms of the access to data. The next thing is, again, you know, notification of problems. So both in terms of the care home and the clinical staff, you know, are they alerted well enough in time before the condition of the resident declines so rapidly that it has to lead to an ambulance call out or a hospital admission? Can there be sufficient notifications given in time to ensure that the resident can be maintained within the care home and stabilized? Now, the one downside of using paper copies or just remembering things is that you can't bring it out to help you. So there's no intelligence. Yes, you have the data in papers, but what does that tell you? It doesn't speak anything. So the advantage of digital systems is that it helps you in deriving intelligence from the data that you've recorded. So what we've tried to do is answer this and a lot more issues that we currently face within care homes. So we have provided an easy and simple monitoring of the physical health condition of the residents with a minimal risk of missing any recorded data. There are sufficient prompts within the system to prompt the care worker whether they've missed out a vital sign only because, you know, they can't record it, or because they definitely can't record it because they haven't been given the consent or whatever. So there are adequate reasons that they can capture if they're not recording a vital sign. Now, there is increased compliance because we have automated a lot of the escalation workflows, and that depends on the new score as a result of the vital signs taking. So it moves from the sort of the general low score escalations to the urgent to the emergency and who to contact in which event. Now, at the end of the journey is a structured communication, which the system helps provide. Now, both the vital signs as well as the structured communication can be printed out and handed over to the ambulance staff who come to collect the resident if that is the event that lands up. So we've got that as well. And of course, the SBARD, which we're talking about repeatedly about the structured communication, prompts the care worker to almost have a script ready when they go to speak to a clinician. So it's all ready, they know what to talk, and then they can document what the response is and what the decisions are. The aim really is to reduce the cost of hospitalization, deaths in hospitals, to reduce the call outs to ambulance, but more importantly, to improve the health of the resident. Let's try and prevent the resident from not deteriorating to a state where such an event is required. We have intuitive dashboards, both at the resident level as well as the care home level, just to monitor residents. It gives you prompts on who's next due, whether there've been overdue vital signs or breaches that have happened. So all that's in place. And of course, like I said, you know, it provides you guidance on whom to contact if help is required. So what we've seen is through the ONS report, between March and June 2020, we had the top 3 reasons for death in care homes: dementia, Alzheimer, and COVID-19. 2 of these we've captured quite explicitly within the system, one's dementia and one's COVID-19. Not to say that no other condition can't be captured, it is within the remit of Restore 2, but taking it to the next level where we're responding to what is happening within the community. So now, obviously, you know, Jamie's already talked about the wave 2. So we all know winter is approaching and we're already seeing a rise in cases again. So what would be fantastic is for technology to help, you know, technology to help effectively monitor signs of deterioration and provide that sort of timely intervention to the residents, so that we can reduce deaths, we can reduce hospital admissions, we can reduce the burden on the NHS and allow care homes to thrive. So there have been studies already done with the paper Restore 2, and there is evidence that it has led to reduction in 999 calls and conveyances to hospitals. It has avoided hospital admissions and reductions in the length of stay. It's also helped in the decision-making and identification of deteriorations, and of course the sort of interventions they receive from other clinical professionals like GPs, out of hours and ambulance service. What we envisage is that the digital version of this is going to just scale up the benefits, but also enhance the level of governance it provides, the level of monitoring and alerting it provides. One of the things that came up was that during the night, a lot of the times, the vital signs of residents may not be taken. So the system does provide for overdue alerts, but if there are breaches that start occurring, it actually gets escalated to managers or whoever it is you want to actually state in your system. So there is that level of governance and monitoring that you can effectively take benefit of through the system. And of course, the interoperability. So if we are to communicate with GPs and they need to see the vitals or the SBARD and contribute to it, or the telehealth services, or communicate with other system vendors, that's possible because we have interoperability built in. So very quickly, and I'm happy to give a more detailed demo. I just think there wasn't that much time, and I know everybody would have certain questions, but happy to give a detailed demo to people interested. But just briefly, the sort of features that we have is obviously the resident profile with you know, the area where you can mark a patient as temporarily or permanently discharged, and we also have the disease status. You can also mark a patient with dementia or requiring scale 2 SpO2 vital signs being read rather than scale 1. And that's got some sort of role-based access, so it's not available for everybody to put a person on scale 2, but we have certain controls in place. We then have the soft signs with COVID-19 symptoms, and I'll show you a screenshot of that in a minute. And then there's the emergency with escalation to 999 and an SBARD, which you can either fill the complete thing or do a really short, quick one because you need to escalate an emergency matter. Like I mentioned, we've got the vital signs and the calculation of the news, which can be passed on not just to the GP, but also to the ambulance staff if required. We've got additional vital signs, and like I mentioned, there's a dementia aspect to it, and the pain scale changes to the dementia one if you do want the patient or resident on that. The SBARD, the structured communication with clinicians, you can state what's normal for the resident, and a lot of the times, even though the vital signs scores may show it to be abnormally high, that may be normal for the resident, and the system allows you to capture that so that the care worker can have a look at it. And then eventually, finally, we've got the vital sign reminders and reach alerts. There are other features, but these are sort of the key ones. So here's a screenshot of how the resident dashboard looks. It's a very small snippet of the entire screenshot, but you can very quickly see that the last score of this resident was within the very low bandwidth. We've used the same colors as news does. So the 0 to 2 is a pale yellow. So you can, just by the color of the background of the graph, you can tell that the latest reading, which is here on the right hand side, was a 0. So just the color helps you say what's happening. And then we've got the individual graphs of each of the vital signs. There are other things below just to tell you what's due and what's not. Here's the emergency, and all the icons and stuff, they're meant to be not just conformant with Restore to, but also to help with standardization and easy visual cues, because a lot of text doesn't help.
Rahel, I just need to highlight a bit of time here. We've got 15 minutes left, and we've still got one more speaker to hear from. So I'm conscious that Stuart needs to leave, bang on for another meeting. So if we can just wrap up in the next couple of minutes, please. I'm sorry to rush you.
No problem, Katie. I'll be done soon. All right. Yeah. So just over here, the soft signs. The red bits are the COVID, and you can switch on the COVID-19 symptoms. And if you mark more than 2, like I said, it does put you on a different pathway, so you can start capturing the COVID-19 symptoms as well. Here is just a little chart on what's happening with the residents, so that you can go and take the vitals. Obviously, if things have breached, then there will be further prompts. So this is my last slide. So Katie, it should be all right, hopefully. So where are we in our journey? We're in a growth of technology right now. We've completed phase 1 of the digitization, and we're in preparation for phase 2, which will focus a lot on the integration with other clinical systems, so GPs, telehealth, and others. The first pilot of the system has begun in West Hampshire, and we're hoping that it'll complete by the middle of October, and we start getting some results and feedback. And we're also planning for the second pilot. And then after that, we'll start with the initial controlled rollout of Direcht Restore. So thank you, everybody, and happy to answer any questions. And thank you, Katie, for your patience.
No problem. Thank you so much. Great presentation. It's great that we are seeing digital solutions now to support Restore 2, which is being a tool that's being endorsed now by the British Geriatric Society on the back of the LEDER report as well, and it's now in the guidance for admission to care homes as well. We'll come back to that in a minute, and if it's okay with you, Rahil, we'll come back to questions for yourself. I'm very conscious that we need to hear from Stuart, and that he's got to leave fairly timely. So if I can ask Stuart to present now on behalf of Rinicare and your innovation, and then we'll wrap up with questions at the end.
Great, thank you, Katie. So my name is Stuart Grant, and I'm the Chief Medical Officer for Rinicare. We're a SME based in Alderley Park in Cheshire, and our focus is on developing innovative technological solutions for healthcare problems to try and facilitate more efficient delivery of care, meet the challenges of staff shortages and rising costs, and ultimately improve patient safety and outcomes. I want to talk today about two of our systems. The first one is Prime, which focuses on identifying patients at risk of deterioration and allowing complete physiological assessment outside of the hospital environment. And the second one is Safe, which is a technology that we've developed to try and reduce patient fall events both within the hospital and outside of the hospital. So Prime is a solution that's been designed to really allow clinicians to fully assess patients outside of the hospital environment. By using it, clinicians or non-clinicians can assess patients and can transmit that data to anywhere in the world, which allows more efficient treatment decisions to be made and should lead to improved patient outcomes. The key features of Prime are it allows complete patient assessment to facilitate calculation of early warning scores such as News and News 2. Data from wireless sensors is collected via an Internet of Things Rinicare proprietary hub, and this includes data from pulse oximeters, 12-lead ECG, blood pressure monitors, temperature monitors, and other sensors which can also be integrated. It allows real-time waveform data to be displayed and captured, and this data can then be transmitted to anywhere outside of the environment that it's captured, either in a paramedic situation or a care home setting, or even in general practice. And the system's been piloted in all of these areas. So the benefits of Prime are, firstly, it's completely wireless, so it's easy for healthcare professionals to apply to patients. It's efficient, so it's a simple login that's required, and it's easy to visualize data. It allows really detailed, comprehensive information to be captured for the patients. And in terms of, as a doctor, the only thing that you can't do with a Rinicare system is to actually physically place your hand on the patient. So we've even trialed incorporating a wireless stethoscope to allow a really comprehensive patient assessment. And it's versatile in that it can be used in any setting. It can be used either within the hospital or out of the hospital. So as I'm conscious of time, I want to quickly move on to Safe. And Safe is another technology that we've developed to address a really important area in healthcare and in the population in general, that the earlier speaker alluded to, and that's falls. And it's designed to really identify patients who are at risk of experiencing an imminent fall event and try and provide a window of opportunity in which that fall event can be prevented. It employs innovative thermal imaging combined with artificial intelligent algorithms to try and identify those patients who are at risk of falls. So essentially how it works is a thermal camera is installed above the patient bed space. It allows monitoring to be performed 24/7, so it works in the dark. Alarms can be customizable based on patient position identification, and these can then be accessed by the clinical team on handheld portable devices. It also incorporates an incident log, which importantly allows staff to identify patterns of behaviour that lead up to potential fall events. The beauty of the system as well is that as it's a thermal image, patients can't be identified from the software. So it's, in terms of patient confidentiality, it's very appealing. So I just want to show a brief video of how it works. Should only be a minute. Great. So I hope that illustrates how the system works and how it can be a benefit in the healthcare infrastructure. It's clearly vigilant. It works 24/7. It's discreet. Patients aren't identified through the imaging process. It's precise. It uses the latest thermal optics technology, and alarms can be customized. So patients who are at low risk of falls, alarms can be adjusted to avoid false positive alarms. And this system's currently on trial in Lancaster and Morecambe Bay hospitals. So I'd like to thank the Innovation Agency for the chance to present on our products today. And if anybody would like any further information, then please feel free to get in touch.
Thank you so much, Stuart. Just like to highlight that I'm not sure if there was supposed to be some audio on there. I didn't get it, and I think maybe somebody else didn't either. So if you can send us that link afterwards, I'll make sure that that's distributed throughout the participants today,
Okay.
Stuart.
Great.
But yeah, thanks very much. I think for me as a clinician, it's really exciting that we've got sort of tools available to do remote monitoring, and that we can do this successfully now, and that there's a way of communicating that information across the system as well, but that it can create a News 2 score as well is absolutely crucial. So I'm quite excited about that. So I'm just very conscious of time. We have about 11 minutes left before we wrap up, and I just wonder if we have any questions in the chat box, or if anybody has got anything in particular that they'd like to ask. I think, Andrew, a couple of questions have been sent to you in regards to Rahel, am I right?
Yeah, so I haven't, nothing in the Q&A box currently, but one of the questions for Rahel was regarding the transfer of information when patients or residents maybe need to be moved to another location, maybe conveyed by ambulance to hospital, or I know you talked about interoperability, but is there a way of conveying that information in a straightforward way?
So there are two things that we're doing for that. One that we've done pretty instantly, because we can do it, is we've got the vital signs captured, the last 10 vital signs captured for the resident, as well as the SBARD available as a printout, which you can hand over to the ambulance staff. So in the meanwhile, while we're getting the integration between different systems sorted, so the data can pretty much go from A to B instantly, this option is available. So the ambulance staff get pretty much what the care worker has captured in the care system.
Okay, great. Thanks for that. I'm just looking, there are a couple of questions in the chat box now. So one for Stuart. Are you able to confirm, Stuart, that Prime can now calculate News 2?
Yes.
Great.
Great, nice and simple.
Simple answer, brilliant, thanks. And then another question in the chat, and again it's for Rahel. Is there a planned evaluation for Direcht Restore 2?
That's right. We've already started with the first one. It's being led by the West Hampshire CCG. So all feedback and evaluation results of digital Direcht Restore will be provided and assessed by West Hampshire CCG. But there is another conversation as well happening about another pilot. I can't really talk about it because we still need to have more confirmations. But yeah, once we have that, we should have some white paper published on it.
That's great. Thanks for that, Rahel. So if I can encourage, in the last few minutes, encourage people to put their questions in the chat box. I don't know if we have any questions from any of our other panelists. If not, then I was going to ask Stuart again around the safe innovation that we've seen today. Again, and it's around that transfer of information. So could it be used, I know you're piloting within Morecambe Bay and that's an acute setting, could it be used in a community setting such as a residential home or a nursing home? And if so, how would that transfer of information work? Is there a hub You know, how does that work within those settings?
Yeah, absolutely. I mean, it can work either within a hospital or within a care home environment. In terms of the transfer of information, I mean, it's transferred via a wired infrastructure, but then the healthcare practitioners can get access to that on remote medical devices via a web application that's hosted on the trust intranet or within the care home environment. In terms of transferring the information, because it's designed to sort of dynamically produce updates on patient position, I'm not sure how relevant transmission of that information to secondary care would be. We are investigating what additional information we can gather on patients from thermal images, so that may well be something to look at going forward in terms of extra information that secondary care may want to have access to.
Okay, that's great. And do you think there is potential applications in, I'm thinking kind of actually in people's own homes, and linking in with telehealth services?
Yeah, absolutely. It clearly relies on the bed being in a certain position. So as long as the bed not moved, it could actually be used in any environment. And one thing that we're working on at the moment is trying to develop algorithms that predict an individual's patterns of behaviour to identify when they're at risk of getting out of bed, to give us a longer window than the 15 or 20 seconds that we currently have, based on our initial work.
You can see lots of applications from I'm thinking for people who have dementia. It would be particularly useful, I would have thought, and people again who are, you know, to link it in with the kind of falls assessment for people who are at risk, at high risk of falls, then it would be really useful for that cohort as well.
Yeah, absolutely, and that's the groups in patients that we're looking at initially. Those that are identified as being at high risk could benefit from this system, because it gives the nursing staff and the clinicians that extra bit of time to try and hopefully prevent the event from occurring.
Great, thanks, Stuart. I think we've just got a couple of questions, last couple of questions in the chat. So from Gemma, oh yeah, sorry. So could you say the Safe Steps app name again? I can't find it on the Play Store.
Yeah, so it's not, as I was saying earlier on, it's not a downloadable app. It's a web app, which is accessed through a web browser. You would need to have an account set up by yourselves. And there's some further information on our website, so www.safesteps.tech, TECH. You'll be able to find out some information. And as mentioned before, if anybody is interested in finding out how we can help reduce falls and reduce risks of falls happening, or ultimately track COVID symptoms across care homes, then please get in touch with me. My name is Jamie, and it's again very simple, jamie@safesteps.tech.
That's great. And then one final question from Samson around, in terms of supply, how many can be produced? I've just asked you, Samson, if you can put in the Q&A which product you're referring to.
Yeah, I've just done the same. I'm wondering if it's Rinicare, but I might be wrong.
Yeah.
I'm jumping to conclusions there, Samson. I'm really sorry.
And if it is Rinicare, is it safe, or is it the Prime that you're talking about?
Rinicare Prime.
Yeah, I mean, in terms of Prime, we have about 50 to 100 in stock at any time at the moment, and then we're an SME. We've explored options to outsource, increase production, but you know, clearly it depends on how many we're talking, whether it's, you know, hundreds or thousands. And the same process for the Safe system as well.
Super, thank you.
Great.
So I
hope that answers your question, Samson. Sorry, Katie.
No, that's no problem. We're talking over each other again. We're quite good at doing that, aren't we?
Yeah.
So we have about 2 minutes left. So I think it's a great opportunity to wrap up and sort of conclude our big innovation conversation for today. Massive, massive thanks to all of our speakers who have given up some time to tell us a little bit about the innovations that they've developed and how they can be used. I think it's a really exciting time for us and for them, and for everybody that's attended today. We are in a real challenging time, which is changing quite rapidly. We're seeing our ways of work changing. We're moving to a world of remote monitoring, and where digital solutions are the way forward. So I hope this has really stimulated some thought and some appetite. If you'd like any further information about any of these innovations and products, then please come either via us at the Innovation Agency, or you can go through to the speakers themselves, but we're more than happy to pass on information. So thanks very, very much for giving up your some of your busy time over a lunchtime period as well. We really appreciate it, and we look forward to working with you sooner. So that's great. Thanks ever so much, and we'll speak to you soon. Thank you.